Assalamu alaikum. I would like to welcome you to another series of the universal topics. My name is Nakshabandi, and I'm today going to speak to you about the management of acid-base and electrolyte imbalances. Our goals in this talk will be to review the physiological basis of electrolyte and acid balance in the body, to identify diseases and conditions that are likely to cause or associated with acid-base and electrolyte imbalances, to correct electrolyte and acid-base imbalances, and to perform careful calculations, checks, and other safety measures while correcting acid-base and electrolyte imbalances, and to monitor response to therapy through history, physical examination, and selected laboratory investigations. These are the topics that we're going to start with, and to start with, we're going to be speaking about revision of applied physiology. I'm going to identify some important definitions, give you some normal values of the body. We're going to identify the regulation of pH and the role of buffer system, and I'm going to give you some idea about the Henderson-Hasselbalch equation. To start with, acid is a substance that can yield hydrogen ion when dissolved in water, i.e., it will release proton or H ions. In contrast, base is a substance that can yield hydroxyl ions, and usually it can accept protons or hydrogen ions. So what is the normal pH? pH is a negative log of positively charged hydrogen ions in a given media. And each unit change in pH is equivalent to a tenfold change in hydrogen ion concentration. pH ranges is usually between 0 and 14. If hydrogen ion is high, the solution will be acidic, and that's a pH of less than usually 7. And if the hydrogen ion is low, the solution will be basic or alkaline, and the pH will be more than 7. pH of 7.4 is equivalent to a hydrogen ion concentration of 40 nanomoles per liter. So what are the pH values in our body? The extracellular fluid carries a pH of 7.4. The blood carries a pH of 7.35 to 7.45. And when we say acidosis or acidemia, it means that the pH is less than 7.35. And when we say alkalosis or alkalemia, we mean that the pH is more than 7.45. I'm going to give you some normal values of blood electrolytes and ions. Bicarbonate has a range of 22 to 26 milliequivalent per liter. The partial pressure of carbon dioxide is between 35 to 45 millimeter of mercury. The partial pressure of oxygen is between 90 and 110 millimeter of mercury. Sodium is between 135 and 147 millimole per liter. Potassium is between 3.5 and 5 millimole per liter. Magnesium is between 0.8 to 1.3 millimole per liter. And calcium is between 2.2 to 2.6 millimole per liter. So these facts need to be kept in mind. The body usually tends to produce more acids than bases, and the balance is essential for hormones, enzyme functions, and other vital cell functions. Most enzymes function only will work within a narrow pH ranges, and this also can affect the hormone functions such as insulin, which can be denaturated with acidic pH. Acid production is usually by metabolism of lipids and proteins, and the cellular metabolism usually produces carbon dioxide, as we can see in the equation provided. Acid-base balance can also affect electrolytes such as sodium, potassium, and chloride. Now we're going to speak about regulation of acid-base balance. What do we mean by balance? It should be between the production and retention of acids and bases. Usually, the acid-base balance acts through two mechanisms. The first line is chemical buffers, and the second line is through physiological buffer system. When we say chemical buffers, this is usually found in all body fluids, and usually the weak acids are good buffers since they can tilt a reaction in the other direction. However, strong acids are poor buffers because they make the system more acidic. When we speak about the physiological buffer system, we mainly speak about the respiratory center and lungs, which usually has a rapid elimination effect, and the kidneys, which usually tend to have a slow elimination effect. So what is the role of the respiratory system? Usually it only works with volatile acids and acts through exhalation of carbon dioxide, and usually it is a powerful buffer system, and usually it doesn't affect fixed acids like lactic acids, and we can see from this equation that the combination of bicarbonate with hydrogen ions can lead to carbonic acid formation, which can dissolve easily to water and carbon dioxide. Body pH can be adjusted by changing the rate and depth of breathing, and usually it takes several minutes to hours for this to correct. In normal situation, the increased carbon dioxide production stimulates the respiratory system and can be matched by an increase in alveolar elimination of carbon dioxide. If a patient has a total ventilatory failure for more than 20 minutes, this will usually produce a profound acidosis with an arterial partial pressure of carbon dioxide of more than 110 millimeter of mercury and a pH of usually less than 7.03. However, renal failure for this length of time has usually no effect. When we come to the kidneys, usually they act through elimination of large amount of acids, and usually they can excrete bases as well. They can conserve and produce bicarbonate, and it is the most effective regulatory system of the pH. If the kidney fails, the pH balance usually fails, and it may take several hours to days to normalize the pH through kidneys in comparison to the respiratory system. Usually the kidneys will deal with the hydrogen ions through three mechanisms: A, buffer system, B, formation of ammonia, and C, through reabsorption of bicarbonates. We can delineate the effect of the buffers in the following. Usually 20 to 30 millimole of hydrogen ions are excreted daily by the conversion of monohydrogen to dihydrogen phosphate as seen in the following equation. In addition, the kidneys can lead to the formation of ammonia. Ammonia, as we know, is formed in the tubular epithelium, and 60% is formed by the deamination of glutamine, and 30 to 35% is a form of free circulation in the arterial system as an ammonia. This ammonia diffuses through tubular lumen and binds to hydrogen ion to produce an undiffusible ammonium, which is usually excreted. 30 to 50 millimole of hydrogen ions are excreted daily, and this may rise to 700 millimole daily in severe acidosis. What about reabsorption of filtered bicarbonate? 85 to 90% of filtered bicarbonate is absorbed in the proximal tubules of the collecting system. Carbonic anhydrase, which is usually present within the renal tubule, catalyzes the hydration of carbon dioxide to carbonic acid, which then ionizes to hydrogen and bicarbonate ions. Acetazolamide diuretic, which is usually a calcium anhydrase inhibitor, blocks this mechanism and leads to reduce the acid excretion and large amount of sodium bicarb, which usually excreted with the fall of plasma bicarbonate level. The reabsorption of bicarbonate to the bloodstream and hydrogen ion excretion in the urine is exchanged usually with sodium. In cases of severe acidosis, it takes usually 5 days to reach the maximum response when 700 millimole of hydrogen ions can be excreted daily. Factors that affect renal tubular hydrogen excretion will include the luminal pH, intracellular acid-base status, functional extracellular volume, the parathyroid hormone, and the mineralocorticoid activity and potassium status. For example, If we are dealing with a hyperaldosteronism, this will enhance distal tubular sodium reabsorption and hydrogen and potassium excretion. Now we focus on chemical buffers. The buffers usually function almost instantaneously, and it acts through a combination of a weak acid and/or a weak base and its salts. It is the first defense mechanism towards imbalance, and its actions aims to resist changes in pH. And here we have three main buffer systems: the bicarbonate system, the phosphate system, and the protein system. The bicarbonate buffer is usually formed by sodium bicarbonate and carbonic acid. The body tends to maintain a 20:1 ratio of bicarbonate to carbonic acid, and this can be elaborated in the following two equations. The hydrochloride acid will bind with sodium bicarbonate to form carbonic acid and sodium chloride. The carbonic acid also can bind with sodium hydroxide to form sodium bicarbonate and water. What about the phosphate buffer? The phosphate is a major intracellular buffer. It has a major role in the elimination of hydrogen via the kidneys, and it is essential within the red blood cells. It assists in the exchange of sodium for hydrogen and has the following reaction to compensate the excess hydrogen ions. Usually the hydrogen will bind to hydrogen phosphate to form a hydrogen phosphate ions. This can combine also with hydroxyl ions to form water and hydrogen phosphate ions. What about protein buffers? They include amino acids and also the hemoglobin buffer system. Hemoglobin usually works in the blood and interstitial fluid, and usually it will bind the carbon dioxide, binds and transport hydrogen and oxygen, and participate in the chloride shift on the cell membrane, and maintains a blood pH as hemoglobin changes from oxyhemoglobin to deoxyhemoglobin. What about amino acids? The amino group usually accept a hydrogen ion. The carboxyl groups gives usually a hydrogen ion, and the side chain that can buffer hydrogen are usually present in over than 27 known amino acids. In this illustration, we can see within the red blood cells, the reaction usually, the carbonic acid can dissolve into hydrogen ions and bicarbonate. And if the hydrogen ion dissolve and pass through the red blood stream, usually it goes to the kidneys and will stimulate the kidney to increase the rate of hydrogen secretion in order to correct the pH. On the other hand, this also can stimulate the respiratory system in order to adjust the rate of breathing. If the carbonic acid through carbonic anhydrase is dissolved into carbon dioxide and water, this can also pass to the bloodstream, and it circulates and goes to the respiratory center through the brainstem to adjust the respiratory rate and probably increase the carbon dioxide given away. Now we come to a very important equation, which is the Henderson-Hasselbalch equation, and this is usually an equation used between the pH and the bicarbonate carbonic acid buffer system in the plasma, and it helps to calculate the pH. The equation states that the pH is equal to pKa plus the log of a molar concentration of a conjugate base divided by the molar concentration of undissociated weak acid. pKa is defined as a negative log of the ionization constant of an acid, while the pH is the negative log of the hydrogen ion concentration. We move next to the electrolyte acid-base disorders. We have two main disorders, the acidosis and the alkalosis. Acidosis is defined as a blood pH of less than 7.35, and it is due to the overproduction of acids, i.e. hydrogen ions, or the loss of bases. While alkalosis is defined as a blood pH of more than 7.45, and usually it is due to the production of acids, ion, or the accumulation of bases. What is the meaning of compensation, complete compensation, and partial compensation? Compensation, where the body responds to acid imbalance. The complete compensation is the body's success to return normal limits of acid-base balance. However, partial compensation refers to when the body return is not fully corrected and range is still outside the norms. In the interior body environment, there is usually a balance between the amount of carbonic acid and bicarbonate buffers in conjugation with sodium, potassium, magnesium, and calcium bicarbonate. And the ratio, as we mentioned before, between carbonic acid to bicarbonate is 1:20. What are the types of acidosis? Respiratory acidosis happens in the following condition: depression of the respiratory center in the brain that controls breathing rate, for example, with the usage of drugs or head trauma, paralysis of the respiratory or chest muscles, emphysema or chronic obstructive pulmonary disease, adult respiratory distress syndrome, pulmonary edema, and pneumothorax. Usually, the respiration will fail to wash the carbon dioxide from the blood. This will lead to hypercapnia, which is a high level of circulating carbon dioxide, usually more than 45 millimeters of mercury in the blood. This will lead to increased formation of carbonic acid in the cells, resulting in more hydrogen ions formation. How does respiratory acidosis manifest? Usually, the patient will have breathlessness, restlessness, lethargy and disorientation, tremor, convulsions, and this might lead to coma. Usually, the respiratory rate initially will be rapid, then gradually will be depressed. The skin will feel warm and flushed due to the vasodilation caused by the excess carbon dioxide. Now we move to metabolic acidosis. It happens when there is a loss of bicarb, and this can be seen from GIT sources such as diarrhea, small intestinal or pancreatic fistula, or ureteroenterostomy. And also it can be related to kidney disorders such as renal tubular disorders or acidosis, calcium and carbonic anhydrase inhibitors, or renal dysfunctions. Or the metabolic acidosis can happen from accumulation of acids such as lactic acids or ketones, and this can be easily seen in patients with diabetic ketoacidosis or with salicylate overdose and failure of the kidneys to excrete hydrogen ions. In metabolic acidosis, there will be loss of bases which result in bicarbonate deficit, and the blood concentration of bicarbonates drop below 22 milliequivalent per liter and result in metabolic acidosis. How does the patient manifest? Usually, the patient will have a headache, lethargy, nausea, vomiting, and diarrhea, decrease the cardiac output, oliguria, and in diabetic ketoacidosis, the patient might have an acetone breath, and this might lead to coma and death if untreated. What about alkalosis? Respiratory alkalosis happens when there is an excessive washout of carbon dioxide, which leads to decrease in carbonic acid in the cellular media, and usually the partial pressure of carbon dioxide is less than 35 millimeters of mercury, and this is defined as hypocapnia. And by the way, this is the most common acid-base imbalance. The respiratory alkalosis could happen in any condition that stimulate respiratory center, such as oxygen deficiency at high altitudes, historical hyperventilation, pulmonary diseases, and congestive heart failure, which usually caused by hypoxia, acute anxiety, fever, anemia, and early salicylate intoxication such as aspirin toxicity. In metabolic alkalosis, there will be an excessive bicarbonate in the blood, and the bicarbonate is more than 26 milliequivalent per liter. What are the main causes of metabolic alkalosis? Number one is the loss of hydrogen ions, and this can be seen with renal disease such as Cushing syndrome, hyperaldosteronism, or with drugs such as thiazide, furosemide, and corticosteroids, or with GIT disorders such as vomiting or high intestinal obstruction. Also, it can happen with the gain of alkali, such as administration of bicarbonate or milk alkali syndrome. How does the patient manifest if he's having or she's having metabolic alkalosis? They will be mainly related to the depletion of electrolyte. The respiration will be slow and shallow. There will be a hyperactive reflexes, and maybe the patient will have tetany. hypokalemia, and ECG changes such as atrial tachycardia and dysarrhythmias. We move now to the approach to the patient. In patients with acidosis, as we mentioned, the clinical manifestation will be the CNS dysfunction due to decreased synaptic transmission with generalized weakness. Severe acidosis usually will cause disorientation and it might lead to coma. The laboratory finding in patients with acidosis will be a pH of less than 7.35, a bicarbonate level of less than 22 milliequivalent per liter, and this will raise the suspicion of query metabolic cause, or a partial carbon dioxide of more than 45 millimeter of mercury, which might raise a suspicious cause of respiratory. What about the clinical manifestation in patients with alkalosis? Usually the patient will have numbness, lightheadedness, overexcitability of central and peripheral nervous system, which might lead to nervousness, muscle spasm or tetany, convulsions, and loss of consciousness. What about the laboratory findings in patients with alkalosis? Usually the pH will be more than 7.45. The bicarbonate level will be more than 26 milliequivalent per liter, and this might raise a suspicion of metabolic cause. A partial carbon dioxide level of less than 35 millimeter of mercury, which might raise a suspicious cause of respiratory. Now we move to treatment and monitoring of patients with electrolyte imbalance. First of all, we're going to mention the blood gas analysis methodology. The patient usually is followed with heparinized arterial blood gases measurements. The sampling syringe should contain enough heparin, usually 100 units per ml, because we need to keep in mind that an excess heparin usually will reduce the measured pH, and the measurement should be undertaken immediately since metabolism will continue within the blood cells, thus it may raise the partial pressure of carbon dioxide. What about the interpretation of arterial blood gases? We need to determine the following. In patients with acidosis or alkalosis, we need to look at the pH. If the pH is more or less than 7.35, and we need to mention to determine whether it's a metabolic or respiratory in nature. So we need to look at the bicarb level, and usually it is towards metabolic etiology, or the partial carbon dioxide level, which is usually tend to be towards respiratory etiology. And then we need to mention whether it's compensated or not, and if the change is within the normal range, it means that the body succeeded in compensation. So three major elements need to be determined after measuring the ABG, which is the origin of the metabolic imbalance, whether it's a metabolic or respiratory, whether it's compensated or not compensated. Then we move to the proper treatment. Proper diagnosis is the key treatment, and the aim of the treatment will be to eliminate the primary etiology, to help the body to achieve the compensated status, and to monitor of the outcome, which is very important to avoid the overcorrection and reverse the change of the pH status. So in patients with metabolic or respiratory acidosis, the lab changes will show the following. A pH will be low, a bicarb level is usually low, and partial carbon dioxide has no change. This might raise the suspicion of metabolic etiology. When the pH is low and the bicarb has no change or within the normal, and partial pressure of carbon dioxide is high, this might raise the suspicion of respiratory etiology. The clinical findings usually the body will attempt for compensation, so a hyperactive breathing usually will work as a respiratory buffer, and the acidic urine excretion will work as a renal buffer. So what is the treatment of metabolic or respiratory acidosis? Sodium bicarb is the usual first-line therapy that can be given, and usually we give it in a concentration of 8.4%, which is 1 millimole per ml of sodium bicarb. It is usually a hypertonic solution, and it might cause irritation to the skin, and we need to be a little bit cautious about sodium overload, which is a major risk, especially in patients with cardiac diseases. THAM is another therapy that can be given, which is the trihydroxyl methyamino-methane, which can be used as a non-sodium containing buffer in patients with cardiac risk. What about the treatment of metabolic and respiratory acidosis? Lactate solution can be given, and usually this lactate will be converted to bicarbonate ions in the liver, and usually will compensate for the excess acid. For respiratory acidosis, we need to improve the ventilation to avoid accumulation of carbon dioxide. And for chronic respiratory acidosis, such as chronic obstructive pulmonary disease, there will be no place for alkali therapy. I'm going to give you a few words about lactic acidosis. Lactic acidosis are of main two types. Type A, which is due to tissue hypoxia, and this is usually due to lactate, which is generated faster than elimination. And this can be seen with exercise, shock, or hypoxia. And type B is a non-tissue hypoxia, which is usually due to diabetes, renal failure, infection, leukemia, biguanide therapy of diabetes, paracetamol poisoning, or excess intravenous fructose. If hyperglycemia exists, insulin may be required. And if hyperkalemia exists, when the pH rises, the potassium usually will enter the cells and hemodialysis may be needed. What about metabolic respiratory alkalosis? The following lab changes is usually noticed. The pH will be high, partial pressure of carbon dioxide usually will have no changes, and the bicarbonate usually will be high. And this will raise the suspicion of metabolic etiology. If the pH is high, the partial carbon dioxide level is low, and the bicarbonate has no change or within normal, this might raise a suspicion of respiratory cause. The clinical findings in order to compensate will be a low breath rate. This is due to retaining of carbon dioxide, and alkaline urine to conserve hydrogen ions. What is the treatment of metabolic respiratory alkalosis? Will be to replace excess bicarbonate with fluid containing chloride. And it is also essential to treat associated hyperkalemia, and we can utilize carbon anhydrase inhibitor, which can be used to manage the returned hydrogen ions. So in summary, these are the take-home messages. Acid-base balance is important for enzyme function and establishment of viral cellular mechanisms. The values of arterial blood gases are essential for diagnosis and monitoring of the cause. Some clinical features suggest specific acid-base disorders. These are the two major blood gases that can be seen in alkalosis and acidosis. In alkalosis, if the pH is high, the partial carbon dioxide pressure is low, and the bicarbonate level is high, this will raise the suspicion of a metabolic etiology. If the pH is high, the partial carbon dioxide level is low, and the bicarbonate level within normal, this raised the suspicion of a respiratory cause. What about the arterial blood gases in patients with acidosis? The pH will tend to be low, and the bicarbonate level will be low, and partial carbon dioxide level will have no changes. This will raise a suspicion of metabolic etiology. If the pH is low, bicarbonate level is low, and the partial carbon dioxide level is high, this will raise a suspicion of respiratory etiology. The treatment is directed to primary causes. For acidosis, lactate in IV fluid is usually converted to bicarbonate in the liver in order to correct the acidosis. And for alkalosis, chloride in IV fluid will be exchanged with bicarbonate within the cells in order to correct alkalosis. These are few references. I wish you all the best, and thank you very much for giving me this opportunity.